grade teacher all over again, trying to get the class to come in like right after recess. You know how hard it is to get, maybe like 24 first graders' attention after recess. It is like absolutely unreal. But you guys are much better first grade. I said good evening one time and you were already engaged. So you guys are much better than first graders, I can tell you that. Well, welcome. I'm State Representative Rudy Hobbs, and I represent the communities of Southfield, Lathrup Village, Bingham Farms, Franklin, and Beverly Hills. Now, I know I've chatted with some folks that may not necessarily be from this state rep district, so I think I already know the answer, but I'm going to ask anyway to figure out where our furthest visitor could be from. I think I already know the answer, though, because I ran into someone that came a really long way. You're not supposed to tell them now. You have to let me go through the process to get to you, right? I got to call you out. So, do we have anyone else from Oakland County outside of the areas that I just named?
I own property in Southfield.
You own property in Southfield. She made that clear. So, where do we have a group from over here? West Bloomfield. Well, we named Southfield, right? So any other outside? I know I had Oak Park, and I have Macomb County. Where at in Macomb County? Macomb. That's pretty far. That is pretty far. Do I have anyone else outside of that's in Macomb County? Where? Warren. Warren. And anyone outside of Wayne County? Oakland County, Macomb County. This is my winner. I know it's a winner, right? I mean, I knew this going into this. I told her I would do this. Where are you from? Marine City. So that just lets you know how important health care is, right? That we have individuals that will come from, all over this region to have a conversation about health care. Healthcare is extremely important. At the state level, we talk about it a great deal, and we debate about it a great deal, and we don't always agree. And then, in D.C., they're having the same conversations, and they don't agree about it. And even though we have a law, we still have individuals that call it a bill, but it's a law. It is a law. It is the law of the land. The Affordable Health Care Act is the law, and it's important that we all understand it. And there's been a lot of misinformation about this law. And there's snippets that are in the newspaper and the headlines that say, the extension, we're going to extend the deadline for a year. Well, it doesn't necessarily mean you, but they're talking about someone else, but it's not you. And so what I wanted to do was really have the conversation back home about what this means to us as a community, as organizations, as individuals, because on October 1st, we're going to have some information, and we're going to need to know what to do with that information. Now, here's the thing. Am I going to be the person that's going to stand here all day today and tell you about all the great things about the Affordable Health Care Act? No, I am not the guy that's going to stand here. But one of the things I love to do as a state representative is bring experts into my community to really talk about the importance of different issues. And we had one not too long ago where we talked a lot about transportation, and I thought it was an awesome forum. But today we're going to be talking about healthcare, and we have some dynamic individuals that are going to be chatting with us about that. And so I would say, feel free to ask questions. I think that the speakers will let you know if they want to be interrupted or if we can wait to the end. I will hope that they will kind of give us some guidance on how they will want to move through the presentation. But we will have presentations. I believe there's a short video, and it is going to be very, very important. So I am going to ask you to please ask any question. And if we don't know the answer, I promise you, I will get back to you. I promise you. I have my staff here. Keisha Speech is here along the wall. She is our district director in constituent service. She's wonderful. And then back here is my policy guy. His name is Aaron Kill. He's back there waving a hand. He was my intern when I was a policy advisor for Lieutenant Governor. So you see how much I love my interns, right? And I'll bring them along with me. And then I also want to just acknowledge a few individuals that are in the audience. We have a few school board members with us. Fern Katz is with us. I see Michael Poole from the Southfield School Board, and Betty Robinson is also back there from the Southfield School Board. And we also have a couple city council people here, Southfield City Council. Councilman Myron Frazier back here. And then we also have Jeremy Moss, Councilman Jeremy Moss, who is in the back there, and was also my former district director and constituent service person. We have a great audience, and all of you, I think we're going to have a good time. We're going to chat and have a very honest conversation. So, with further ado, I am going to turn this over. I'm sorry, Keisha is telling me I'm missing someone. Oh. Did I miss someone? Okay. So, this is why you have good staff, right? They stop you in the middle of a conversation and tell you what you need to do. So, as Keisha would say, I really want to thank everyone for coming, right? And also want to thank the Jewish Family Services for the coffee and the cookies. So I really appreciate it. We'll get that over to Perry. And then I'm also doing one other special little thing too. My mother's here with me. Hey, my friend, stand up. Stand up. That's my mother. Because if I didn't introduce my mother, I would have heard about it a little bit later on. So my mother is here with us. So thank you for stopping me. So how about I turn it over to Perry at this point? Thank you.
Thank you, Representative Hobbs. My name is Perry Oren. I'm the CEO of Jewish Family Service of Metropolitan Detroit, and I would like to thank everybody for being here. I would like to thank Representative Hobbs and his staff for putting this together. I'd like to thank the Michigan Consumers for Healthcare and their staff for putting this together, the credit union that we're at for putting this together, my staff that's here, Shane Dole, Alla, and Sarit from Jewish Family Service. And I also, kind of like what Rudy said, I'm not a subject matter expert in this stuff. It's complicated. So I'm going to give you an overview of why this is important from a multi-service agency's perspective. Jewish Family Service of Metropolitan Detroit is a multi-service agency, which means we do a lot of things for a lot of people. We're a non-sectarian agency. We're based in West Bloomfield. We have an office in Oak Park. We serve people in the Tri-County area. Jewish Family Service 10 years ago never thought that we would be in the business of standing up in front of you talking about the importance of healthcare reform or the meaning of healthcare reform, or we never thought we'd be in the business of helping people navigate the difficult service delivery stream of healthcare currently and what it will be. But we're in that business because it takes it takes a village. It takes all of us, from your legislators to statewide organizations to multi-service organizations and dozens of others to help all of us try to figure out what's currently going on and what might go on and how that impacts us. So the story of Jewish Family Service is 10 years ago, we kind of got into this business, if you will, of helping people to access health care, because we realized in our community that there were lots of people that didn't have health care. We created a program that helped people get to doctors, that helped people get to hospitals, that helped people get to prescriptions, whatever basically was necessary. And now we find ourselves with several hundred people who are still helping to access health care, but we're not certain what their health care futures are going to look like come October 1st, come January 1st, come next year. And it's got all of us worried, not just you in the audience who are wondering how this affects you, but also decision makers at organizations like mine, legislators like Representative Hobbs, Michigan Healthcare, Michigan, you guys over there, Consumers for Healthcare, all of us. The importance of having this kind of a forum is because lots of changes are going to be happening. This is a broken record, and all of you know this. And we have to be as best informed as we can. You have before you today, the next speaker, we're really going to bring on the subject matter expert, somebody who's quite qualified to talk to you about what we think is going to be happening and what you all need to do and what your friends and your neighbors need to do to get prepared, and what will these exchanges look like, and what will a Jewish Family Service be doing next year. Again, we've been doing this for years for a small population of people. Our end game at Jewish Family Service and lots of other sister agencies isn't to stay in this business as the Affordable Care Act takes root and becomes the law of the land and sort of influences how we're all accessing health care. So I want to thank all of you for being here to pay attention and ask the good questions. I have many questions too. I don't have answers. When I have questions, I turn, like Representative Hobbs does, to his capable colleagues, his staff, and I have people here who are subject matter experts. They're not going to get the mic, but if you have other questions for people, you can feel free to ask. For instance, Shanda Bronstein, who's in the audience, who is our director of our access to healthcare services, as well as her colleagues who will be able to help you. So I thank you all for being here. I underscore the importance of all of us as community partners, whether we're social service organizations, whether we're statewide organizations, whether we're legislators, all of us to try to wrap our heads around this. My mother is not here. She'd be proud to be here. I love to introduce my mother, but I could call her up later and say I said something about my mother. I'm glad your mother is here. So let me spend a minute on Jewish Family Service and why we're so surprised that in the last 10 years we're in this business. Jewish Family Service started in 1928 with some predecessor organizations. We do a lot of different things. I would say we're a cradle-to-grave organization. We provide services for older adults. We provide counseling services, an outpatient mental health clinic. We provide safety net services. We never thought, again, that we would be helping people get to the doctor's office. We looked around 10 years ago as people were knocking on our door, increasingly calling on our phone, and they didn't have health care. And we looked around, and nobody else was sort of taking up that space. We thought, well, if nobody else is doing this in our community, and this is specifically, while we're a non-sectarian agency, Jewish Family Service, in other words, open to everybody, some of our programs are for specific populations. So our access to health care program at that point, and at this point too, was a program simply for the Jewish community. So we looked around the Jewish community, and we decided that we had to do something because nobody else was going to do this. So we created a program that was helpful in our community, but we realized that it was a short-term, an elegant solution for a small amount of people, but a short-term solution, and then lo and behold, the Affordable Care Act is taking root all over the place, and we are anxious to sort of ride that wave toward getting people who are currently being served through our access to health care program. And we are not, let me be clear, Jewish Family Service doesn't provide health care. We provide access to health care. So somebody who is eligible, whatever our eligibility criteria are, comes to Jewish Family Service, sees a case manager like Allah who's out here, and then Allah will refer that person to somebody who's willing to volunteer his or her services in their offices, the hospitals, prescriptions, etc. So we're not providing the health care, we're providing access to health care. We are excited and nervous about the Affordable Care Act, as we all are. I'm anxious to hear what Don is going to lead us in. He's going to do a presentation in a minute about what this probably means for us. I'm sure there'll be a lot of Q. I hope there'll be a lot of A as well. I know there'll be lots of questions and there'll be some answers. We will keep people posted as best as we can as answers arise, but we know that there aren't all the answers. So, in summary, I'm honored to be here. Jewish Family Service is honored to sort of help sponsor this event because this is, you know, while we serve metropolitan Detroit in the Tri-County area, in some ways this is one of our sweet spots. We serve the whole community. We serve a lot of people in Oak Park, in Southfield, in West Bloomfield, in Farmington Hills. So this is our neighborhood. So it's an honor to be in our neighborhood talking about very important things that are important to you, but they're also very important to our organization. I'm now going to turn it over to Don Hazard, who is the Michigan Consumers for Healthcare. So thanks for having me.
Thank you so much. Thank you, Barry. Jewish Family Services Representative Hobbs, thank you so much for pulling this evening's event together. So my name is Don Hazard. I'm the Executive Director of Michigan Consumers for Healthcare. If you're unfamiliar with our organization, you are forgiven. 3 years ago, we didn't even exist. So the creation of Michigan Consumers for Healthcare was a reaction to the passage of the Affordable Care Act. We are truly living in historic times. Whether we want to take a step back and recognize we are. It's been over 100 years that we've been debating healthcare in America. Literally over 100 years ago, Teddy Roosevelt was running for President of the United States, talking about the need for a nationalized healthcare program. So we've been having this debate in America for a very long time. And we finally have something akin to a national health care program, and there are a lot of decisions that need to be made as far as implementation. So the consumer health community got together with the foundation community, and in reaction to the passage of the Affordable Care Act, they created Michigan Consumers for Healthcare. So we do many things, but in essence, we try to speak for the consumer through this whole process, this whole implementation process. All the other stakeholders have voices, right? The insurance industry certainly has a very, very big voice in Washington and Lansing. Big Pharma has a voice. The hospitals have a voice. Who speaks for the consumer? We try to fill that role. We try to advocate for the consumer in this state. We've been in Representative Hobbs' office several times on different issues, speaking on behalf of the consumer. In addition to doing that type of policy research and policy advocacy, we also do collaborative work. So we represent over 200 different agencies, nonprofits in this state, groups like AARP, Jewish Family Services, American Heart Association, Michigan Disability Rights Coalition, and we try to work collaboratively with implementation of the Affordable Care Act. And that can be like herding cats at times, but still. But we all recognize that we need to work collaboratively to make this important, historic implementation period work for consumers in this state. So part of that process is we are developing a coordinated response to enrollment. In just a couple of months, beginning October 1, we're going to have over 1 million citizens in this state who are going to be eligible, hopefully, for an expanded Medicaid program and also tax credits to purchase private insurance. So over 1 million people in just a few months are going to fall into one of those two categories. Now, Dizzy Warren from my staff is going to be coming up after I'm done to talk a little bit about the efforts that we collectively have to make that assist these people in getting enrolled. I also want to quickly introduce Brett Williams of my staff as well. Brett is an expert on small business and the Affordable Care Act. So if you're a business owner, you have questions on how it impacts the Affordable Care Act, arguably the most knowledgeable person in the state on that subject. So I've been asked to do a background on the Affordable Care Act and also update folks on some of the policy implementation issues that we have to resolve. So there's a slight modification to your agenda. I'm going to be doing both in one presentation rather than doing one presentation, sitting down and coming back later in the evening and doing something else. So as far as explaining the Affordable Care Act, the Kaiser Family Foundation does a wonderful job as far as talking to consumers and trying to figure out ways to convey complicated issues in very simple ways. And just last week, they released a new video, it's only about 6 minutes, that tries to explain the Affordable Care Act in an easy-to-understand way. So we're going to go ahead and we're going to play that video. And at the conclusion of this brief video, I'm going to come back and I'm going to try to explain why we're doing all of this.
Well, it's finally happening. After years of drama on Capitol Hill, a Supreme Court case, a presidential election, and a Mayan apocalypse that could have stopped it dead in its tracks, but didn't, the marquee elements of the Affordable Care Act, sometimes called Obamacare, are about to kick in, and big changes are coming to health insurance in 2014. In the next few minutes, you'll get a pretty good lay of the land by once again watching your fellow Americans, the U-Tunes, find their way through the system. There are 4 main ways nearly all of us will experience health care once the health reform law goes fully into effect. About half of us will get insurance through our jobs, just like today. About a third will get covered by the government through Medicare and Medicaid. About 1 in 10 will buy insurance themselves. And unfortunately, another 30 million of us or so, just under 1 in 10, still may not have coverage at all. But let's begin in the workplace. Many Americans are already covered by their employers, and for them, not a whole lot will change. There will be some new advantages, though, like caps on how much you have to pay out of pocket, and free preventative care. The bigger changes are coming for those who work for larger companies but aren't covered now. That's because the government is going to require companies with 50 or more employees to cover full-time workers or pay a penalty. So, more workers may find themselves covered. Smaller employers won't face the same penalties for refusing to buy insurance, but they'll be encouraged to do so. The government will be setting up special marketplaces to make it easier for small employers to take the plunge. Some will be offered temporary tax breaks if they do, and unlike now, insurers can't inflate prices if some employees are sick. So, many of us will be getting covered at work. A lot of us will be covered with help from the government, just like today. Not much will change for seniors on Medicare. The law has already started helping with prescription drugs and better preventative care, and that will continue. Medicaid, on the other hand, is expanding to cover more of us, especially poor adults, many of whom aren't eligible today. If your income is low, Medicaid will cover you, most likely in a private insurance plan. But there's a catch. The Supreme Court ruled that governors and legislatures of each state should decide whether or not to be part of expanding Medicaid. In states that get on board, the feds will cover almost all the cost. But for those who don't, you may be left with the same options you have today if you're poor. So you'll want to check out your state's decision if you think you might qualify for Medicaid. Even with employer coverage and the expansion of Medicaid, a lot of us will still be left out. For those not covered or who find their work coverage too expensive, a new way to buy insurance on our own will be popping up everywhere. They're called health insurance marketplaces, though they may have a fancier name than that in your state. The health insurance marketplace is like a virtual insurance mega mall. Here you'll find private insurers competing for your business, and you'll be able to pick out how much coverage you want and how much you want to pay for it. From cheaper, high-deductible bronze plans to more expensive platinum plans. Still, all plans will cover a comprehensive set of services like hospital and doctor visits, paternity care, mental health care, and drugs. Most everything any of us need, at least when it comes to medical care. As with Medicaid, not all governors are on board to set up these marketplaces, but the feds will open their own in those states, and so you probably won't notice much of a difference. One big advantage of buying insurance through these new marketplaces is that the federal government will provide most people with a tax credit to make insurance more affordable if you don't have any other options and your income is below a certain level. In fact, most people buying on their own will be eligible for a tax credit and won't have to pay the whole premium themselves. The marketplaces will make sure that insurance companies operate fairly under strict rules. They'll have to offer everyone insurance, even if they're sick. And they won't be able to charge more for pre-existing conditions. Unlike today, men and women will pay the same price. And prices for older people will come down, while young people will pay more. To keep costs down for young people, though, they'll be able to stay on their parents' plans until 26. And buy low-budget catastrophic plans until they're 30. Of course, all these changes still don't mean insurance will come cheap. Most people buying their own coverage will end up paying less with the new health insurance tax credits. But some people will have to pay more, even though many of them will be getting better and more secure insurance. So let's be realistic. Not everyone's going to run out and buy insurance. Some might say, hold on a minute. If I can't be turned down or charged more, why not just wait until I get sick or injured to buy insurance at all? Well, first, you can only get coverage during special enrollment periods. So if you snooze, you may lose. And second, thanks to something called the individual mandate, if you're not insured, you pay a fine, making this option seem not nearly so clever. Still, if you really can't afford to buy in and can't get insurance anywhere else, the government will waive the penalty. So don't panic. By now, you've probably noticed a lot more people will be getting a lot more coverage. Where will the money to pay for that come from? Taxes. Many of them targeted at the health industry itself, even tanning services. Yes, individuals will pay too, mostly the wealthiest Americans, who will be paying more into Medicare. Also, hospitals and insurance companies participating in Medicare will get paid somewhat less. Not painless, but somebody's got to pay. So, as Americans prepare for 2014, how will you be covered? How would you like to be? Now's the time to figure it out and get on the path of setting yourself up for the best insurance at the best price. After all, who wouldn't want that?
Okay, so I think they do a wonderful job, don't they? The Kaiser Family Foundation do a wonderful job of explaining a complicated thing in a very short period of time. So I'm going to try to elaborate a little bit, if I may. And when I do these presentations, I always take a step back and I explain why we're doing this. Why are we doing healthcare reform? And the reason I'm doing that is because if you're of the mindset that this is unnecessary, that we already have the best healthcare system in the world, and why do it? Why bother? Then it's difficult for you to buy into what this is all about. It's difficult for you to buy into this conversation. So I think it makes sense to take a step back and explain why we're doing this. Okay, so I hear this all the time. We have the best health care in the world. I hear it especially from lawmakers. Lawmakers tell me that we have the best health care model in the world. Why are we risking it? With health care reform. So let's address the issue head on. So the United States healthcare model, do we have the best in the world? Well, let's begin with looking at costs. So right now in America, we pay an average of about $8,000 per year for every man, woman, and child in America on healthcare-related costs. Okay? While you look at that number, $8,000 per man, woman, child, keep in mind we have over 31 million Americans uninsured right now. That is the equivalent of every man, woman, and child in the 25 smallest states and the District of Columbia combined. If you don't trust me, go home and Google it and add it up. I did. It adds up to the 25 smallest states in the District of Columbia. So let's compare what we're spending to some of the other healthcare models on the planet. The next biggest spender after us is Norway. In socialist Norway, every person from birth to death has health care coverage. In fact, Norway's health care program is so extensive that physicians in Norway can write you a script for a spa visit. So if a physician believes that a stay at a spa could help you and treat you for depression or some other condition, they can literally write you a script for that, and the national health care program has to pick up that cost. Of course, our neighbors to the north, just Canada, just to the north of us, they're spending about half what we're spending for every man, woman, child. And again, they are all covered. The UK, just $3,000, and in Japan, $2,700. So as you look at that graph, also think about how difficult it is for American industry to compete on a global scale when we have to build these costs into everything we produce. Every car we produce, every TV set we produce, VCR, and if you wonder why we're not producing that type of those types of things anymore in America, part of it is runaway healthcare costs. And also let's keep in mind that business competitors aren't picking up any of that cost. Those costs are being picked up by the government in Norway, Canada, the UK. But logically, you can make the case that, well, we're spending a lot of money for health care, but maybe we get terrific health care, right? If I spend a lot of money on a car, very often I have a really sweet car. So maybe we have a really good health care model, despite the fact we're spending a lot for it. Well, this is actually what we're getting for $8,000 a year for every man, woman, child. 30 other countries are doing a better job than we are of keeping their infants alive. The World Health Organization did a study a few years ago, and they ranked our healthcare system 37th in the world, behind countries like Cyprus, Costa Rica, and Malta. And the Institute of Medicine released a study last year saying that we waste $750 billion a year on things like running unnecessary tests, duplicate tests. Okay, so something had to be done. A lot of folks for quite some while realized something had to be done at some point. So the father of the Affordable Care Act, the individual mandate, is a man named Mark Pauley. And Mr. Pauley was a policy advisor to George Bush Sr., the first George Bush. Mr. Pauley is a conservative economist, and he developed this concept as an alternative to a government-run healthcare system. So this is a conservative advisor to a Republican president, and he's saying to his fellow conservatives back in the late 1980s, gentlemen, at some point this country is going to deal with the healthcare crisis, and we better have a market-based alternative to single-payer, or we are going to have a single-payer model in this country. So Mr. Pauli includes arguably the most influential conservative think tank in America, which is the Heritage Foundation. And in July of 1990, they released their proposal, which we're looking at here, the cover shot of it. And you can see that's July 1990, so this is before Bill and Hillary Clinton. It is not a reaction to Hillary Care. It is exactly as I described it, conservatives trying to come up with a market-based alternative to single-payer, government-run health care. And what the Heritage Foundation said, essentially, is let's make a deal with the American public. And that deal is we will make health care more affordable through tax credits, and you, in turn, are going to purchase insurance. And if you don't purchase insurance, when we give you these tax credits to make it more affordable, we're going to fine you. But even back in 1990, in this original paper that the Heritage Foundation put out, even back then, they acknowledged we were going to have to do an expansion of Medicaid. That's part of their proposal. Because they understood even back then that it doesn't matter how much you give someone in the way of tax credits. If they're too poor, they're not going to buy private insurance. Right? Someone at about 36% of the federal poverty limit right now, a childless adult who doesn't qualify for Medicaid, they're living off about $208 a month. So they're not going to buy private insurance no matter how large of a tax credit you provide them. You're going to have to provide them coverage at that stage. So even back then, they were acknowledging that we're going to have to do an expansion of Medicaid to make this process work. Okay, so of course, Heritage Foundation develops this proposal, but someone has to implement it. So Massachusetts is the first to implement under Governor Mitt Romney. They implemented about a decade ago. And the reason we are replicating the Massachusetts model is because it worked pretty well. Now, in Massachusetts today, 98.1% of their citizens, so only 1.9% of their citizens have no health care coverage. The national average is about 16%. So think about what it means to go from 16% of us uninsured to less than 2% of us being uninsured. A nonprofit organization that fact checks what politicians say and other people say took a look at what was going on in Massachusetts as far as their health care reform. And I'm quoting them there. They say, well, any way you want to look at it, premium costs went down. Any way you want to look at it, costs went down in Massachusetts. And not only was Massachusetts doing a good job bringing costs down, but 60% of those individuals buying insurance in Massachusetts had no previous insurance. So they were getting coverage to people who previously had no coverage. So they're bringing costs down for the rest of us and expanding the population who had coverage. So substantial. So you're probably wondering, what am I talking about with a healthcare exchange bringing down coverage? Well, this is the Massachusetts Healthcare Exchange, or Healthcare Marketplace, we're calling them now. It's called the Health Connector, so that's a screenshot of it. So if you were a citizen of Massachusetts right now, you would go on the web, you would go to the Health Connector, and you would put in all your basic data, and the Health Connector would tell you if you were eligible for the expanded Medicaid program and would help get you enrolled, or it would let you know if you're eligible for tax credits, and you could immediately apply those tax credits to the purchase of your premium. So it's not like you have to wait a year for your tax refund to check to arrive. That wouldn't be very helpful to you. They immediately apply your tax credit to your premium. And the Health Connector exchanges also allow you to compare one plan to another, right? So if you go to Travelocity, you want to buy an airline ticket, okay, you can compare one coach ticket to another coach ticket, or one first class ticket to another first class ticket. That's how healthcare exchanges work as well, or healthcare marketplaces, as we're now calling them. So if you go to the healthcare marketplace, you can compare one bronze plan to another bronze plan, one silver plan to another silver plan, and you can pick the one that makes the most sense to you. And it's very simple to understand the difference between the plans. You're basically deciding what percent you want to pick up, right? The silver plan that picks up 60%, or I'm sorry, a bronze plan picks up 60%, a silver plan picks up 70%, a gold plan picks up 80%, a platinum plan picks up 90%. So it's just like buying an airline ticket. You decide, do you want coach, do you want coach, do you want first class, do you want business class, and then you purchase what is most affordable to you. So it's about creating transparency and competition. Okay, so does it work? Yeah, it works. So a couple of weeks ago, states started reporting their rates for next year. Now, these are what insurance plans are going to sell for next year in comparison to what they're selling for now, this year, without an exchange. In California, rates went down up to 29%. And this is very significant. About a fifth of our national economy is based out of California. So these are significant results. In Oregon, a week later, the rates went down up to 35%. But last week, New York reported their rates, and people were really stunned. So in New York, last week, they reported that rates on average were down 50%. That's not up to 50%, that's the average. An average insurance policy went down 50% in New York last year. And in fact, one policy right now is selling for $1,000. Its equivalent will be selling next year for $308 a month. So a reduction by 2/3. Okay. So how does that work? That works by creating competition. You're forcing insurance companies to compete against one another in a transparent way. Right now, if you want to buy insurance, it's very difficult, right? It's very, very difficult to compare one plan to another. Most people can't do it. It's too complicated. There's all this fine print. Maybe if you're running a small business, you might turn to an agent, but agents often can only sell particular products, or maybe they're reimbursed a higher rate to sell you one product versus another. You don't know that. So you don't know if you're getting the best deal. Exchanges make it very clear what you're purchasing, because you're able to easily compare one plan to another, just like looking at one airline ticket to another airline ticket. So the competition is what drives that down. So in California, for example, I was just talking about California, after their rates came down, 2 insurance companies in California actually begged the state of California to let them redo it. They realized when the rates got posted that they were going to lose market share, that they had been a little too greedy, they'd come in too high, they realized they were going to lose market share, and they begged the state, can we please lower our rates? Can you please let us lower our rates? Because they realized they wouldn't be able to compete at those numbers. Now when you think about that, think about the fact that here in Michigan, our premium costs, our insurance premium costs have gone up 15 times faster than our household income over the last decade. 15 times faster than our household incomes over the last decade. That's based on a Families USA study released last year. So premium costs throughout the country have been completely out of control for a long time, and Michigan is not the exception. But for the first time, we're seeing premiums going down, unquestionably going down, and that's because of healthcare reform, and that's because we're finally forcing insurance companies to openly and transparently compete against one another. So what are we trying to do then with healthcare reform? Well, we're trying to reduce costs. Costs are driving everything, whether we're talking about government, family incomes, it doesn't matter. Healthcare-related costs are a huge driver. We're trying to increase access to affordable quality healthcare. We're trying to protect Medicare and Medicaid, and we're trying to modernize our health delivery system. We're trying to do all that at once. Okay. So how are we going to do that? Well, one of the basic ways we're going about reforming healthcare in America is we're creating a floor of coverage. We're essentially saying to insurance companies, you can't sell junk plans to us anymore. You have to sell us a plan that we can raise a family on. You have to sell us a plan where we can raise a family on. So, for example, over half the insurance policies sold in Michigan right now do not have maternity care. It's a little hard to raise a family if healthcare doesn't cover maternity care. So, what you see here are 10 categories that every insurance plan in America going forward has to sell. This is called the Essential Health Benefit Package. Think of it as the floor. It doesn't matter where you buy your insurance policy next year, whether you buy it on the exchange or off the exchange. Every plan you buy is going to have to cover the 10 categories. Dental and vision coverage for children, substance abuse coverage, habilitative services. A lot on most plans do not cover many or all of these, or put significant restrictions on them, especially when you're talking about mental health services. That goes away come January 1. Every plan you buy, no matter where you buy it, is going to cover all these things. And then it becomes a decision about how much do you want to pick up out of pocket. So, health reform, it helps us in doing away with pre-existing conditions, certainly. That was covered in the video. Every time I do one of these presentations, someone pulls me aside with just a gut-wrenching story about how healthcare costs are ruining them, that they have some pre-existing condition. They can't find coverage, or they have coverage, but the insurance company is just killing them, trying to drive them out of the market by raising their rates year after year. Health reform does away with that. It's already true for children. A sick child in America cannot lose their coverage due to a pre-existing condition. No insurance company can drop them. That will be true for the rest of us come January 1. It also provides lots of financial protections for us. There's something called the medical loss ratio that we should all know about. It sounds complicated, but it's not. It basically tells insurance companies how much of my premium dollar you can pocket, how much can you keep. And the medical loss ratio under the Affordable Care Act is 80%. So when you hand your insurance company $1, your insurance company has to spend at least 80% of that dollar on the group's care. And at the end of the year, if they have not spent 80 cents out of your dollar on your care, they have to literally send you a refund check. At the end of the year, they have to send you a refund check refunding you the difference. It's 80% for individual policies, it's 85% for large group policies. So the idea here is we're forcing insurance companies to spend more money on your care. Last year in Michigan, there was an insurance company that was keeping 55 cents on the dollar. So every dollar you gave them, they kept 55 cents for themselves and their brokers, and they put 45 cents into your care. That goes away as well. So there's a whole assortment of financial protections in the Affordable Care Act. There's a limit on out-of-pocket spending, for example, about $6,000 for an individual. Sounds like a lot, but the largest driver of bankruptcy in America is health-related costs. Most people are not going to be driven into bankruptcy with a $6,000 bill. They will for a $600,000 bill. This caps their liability. So you're going to see a lot fewer Americans being driven into bankruptcy next year. Also, small businesses benefit from health care reform, too. This is the group that is easily the most confused in America as far as the Affordable Care Act works. I talk to small business leaders all the time who are convinced the Affordable Care Act is going to drive them out of business. They're just going to be out of business next year because of all the Affordable Care Act related costs. If you're a small business owner with fewer than 50 full-time employees, the equivalent of 50 full-time employees, there is no mandate that you purchase private insurance. Okay? Therefore, there's no fine if you don't provide private insurance for your employees. There are only benefits to you under the Affordable Care Act. So if you're a small employee and you're currently providing coverage by your choice, you are voluntarily providing coverage to your employee. Right now, the Affordable Care Act will reimburse you up to 35% of those costs. Next year, that goes up to 50%. So what they're trying to do is they're trying to encourage good actors to continue to provide coverage to their employees. But again, no penalty if a small business chooses not to. Large businesses right now in America, over 94% of large businesses already provide coverage to their employees. When we're talking about large employers above 200 employees, it's 98%. So we're talking about a relatively small number of large employers that don't already provide coverage for their employees. You saw in that little video there was a little breaking news that they deferred the large business mandate for 1 year, 2015. That would apply to large businesses, over 50 employees. Okay. We're talking about a relatively small group, and despite what we've heard, employee coverage is going up, not down. It's kind of the squeaky wheel theory. You've got a handful of large businesses that don't want to provide coverage to their employees. They haven't before. They don't want to now. They're making a lot of noise about it. The press covers it, and people think, oh, all kinds of folks are losing their jobs or losing their coverage. In fact, coverage is going up, not down. And also for seniors, the Affordable Care Act helps close the donut hole, and it also eliminates co-pays for all kinds of preventative services. So once a year, you'll be able to do a wellness visit with your physician at no cost to you. Your physician can develop a preventative plan for you. There are no co-pays or costs to you, and that is part of the Affordable Care Act. And then arguably, no question, and the video went at this as well, is the big winner under the Affordable Care Act is women. Women are traditionally targeted by insurance companies because it's more expensive to cover women. They are the child carers. There are complications to child caring. Providing coverage to women is expensive. So insurance companies would much rather cover men. And in the past, they have used a whole assortment of excuses to drop women, including records of domestic abuse. Also, an insurance company cannot charge women more than men as a premium. We saw that in the video as well. There was a study done in Lansing where a woman pays 50% more for the exact same policy as a man in Lansing, despite being the exact same age and being in the exact same health risk group. Simply by the fact that she's a female, she's paying 50% more than her male counterpart. That goes away under the Affordable Care Act. Also, there are some additional changes impacting women significantly. Most of us have heard about the contraceptive issue. The Affordable Care Act is going to require health plans to provide free coverage of contraceptives to women, but also it requires HIV screening, an annual well woman visit at no cost to you, breastfeeding supports, and domestic violence screening. So in the past, your insurance company, knowing that you were a victim of domestic violence, could get you kicked off your insurance. Now the insurance company has to pick it up, the cost of that counseling. So, as I mentioned earlier, the Affordable Care Act tries to encourage everyone to purchase private insurance by making it more affordable. One way it does that is by creating competition and trying to drive down costs by creating competition, and that is working. Right? We saw it work in Massachusetts. Check.org said it will work, and sure enough, it is working. At least in those states that are implementing the law, or not obstructing the law, but implementing the law. The numbers are coming back even greater. Another way it's going to make it more affordable is by providing tax credits. So for individuals who are above 133% of the federal poverty limit, but below 400%, they're going to be eligible for tax credits to make purchasing private insurance more affordable. Now, if you're already getting your insurance coverage from your employer, or you're already on Medicare, or you already have VA care, this is not going to apply to you. This only applies to the uninsured. But this makes it much more affordable for you to purchase insurance. One, because rates are coming down because of competition, and two, then when you purchase a policy that costs less, the government is also picking up some of that cost. So it makes it substantially more affordable for you to do that. And they try to keep it on a sliding scale between 2 and 8%. So someone at the bottom of the scale would be looking to spend about 2% of their household income on their health care costs. Someone at the high end would be expected to pick up 8%. If it costs you more than that, you can receive an affordability waiver. So if you can't afford to purchase insurance, you're not going to be forced to purchase insurance. And then we also talked about that expansion of Medicaid. So as we said earlier, we can't make this work without the expansion of Medicaid. That's because it doesn't matter how big a tax credit you offer somebody, they're not going to purchase private insurance if they're living that low on the poverty income. Unless you're going to buy the policy for them, unless you're going to buy an individual health insurance policy for them. And that's far more expensive than simply expanding Medicaid. So this is a visual representation of what I'm talking about. You may not understand what I'm saying. So this is called the coverage chasm. And on the left, you see all the folks who are on the current Medicaid program. And for a childless adult, you have to be below 35% of the federal poverty limit to apply for Medicaid right now. So those are all the folks on the left of the screen, the folks who are on the current Medicaid program. On the right of the screen, you see everybody who's going to be eligible for tax credits to purchase private insurance. Okay, these are folks above 100% of the federal poverty limit. They can go to their exchange, they'll get tax credits on that sliding scale to make it as affordable as possible, and they can purchase private insurance. The folks in the middle, if we don't do the Medicaid expansion, they're just left out. They don't get Medicaid, and they're not eligible for any tax credits to purchase private insurance, so they get nothing. So we're talking about 500,000 citizens in the state that will get nothing if we don't do the Medicaid expansion. And of course, these folks are going to continue to get sick. They're going to continue to go to the hospital emergency room. They're going to continue to drive up the cost for the rest of us. It's called uncompensated care, when people without coverage go to the hospital. The rest of us essentially pay for it. We pay for it in one of two ways. We pay for it in increased taxes because the government picks up 75% of that cost. We also pay for it in increased insurance premiums. It's about $1,000 hidden tax for all of us in insurance premiums because of uncompensated care. So the governor took a look at this. The video mentioned how the Supreme Court made it optional. The governor took a look at this and said, yeah, this makes a ton of sense. We really should do this. We should do the Medicaid expansion. This is good for Michigan. And the Michigan House agreed. So they adopted a bipartisan Medicaid expansion legislation. Got 78 votes, which is a significant number of votes in the Michigan legislature, where there's only 110 members. But unfortunately, the House went on vacation instead. So if you've been following this issue,
Not the House.
Okay. Sorry.
Not the House.
Senate goes on vacation instead. So many stakeholders, consumers, the hospitals, insurers, have been encouraging the Senate to come back and finish the job. And we actually had a hearing today. Our organization testified at that hearing today. The Senate has the first of 3 proposals the Senate's going to be looking at. I think only one of these proposals is viable. It is a proposal being brought forward by Senator Roger Kahn, very similar to what passed the House. There are 2 new proposals, neither of which have any chance of going anywhere. One is Senator Caswell's bill essentially creates another Medicaid program, except it's a Medicaid program paid for by the state. So rather than accept all the money the federal government wants to give us to expand Medicaid, he wants to spend an extra $600 million to create a separate Medicaid program just so we can say to the federal government, we don't want your money. I don't think that's going anywhere. And there's one other proposal which calls for creating essentially another exchange. So everyone on Medicaid would have to go to this other exchange and purchase coverage there. I don't think that's going anywhere either. And even the health insurance industry said, we're not interested in that. This is complicated enough. It's just too late in the game to be talking about this. Let's just do the Medicaid expansion. So I suspect we're going to get this done, but we need public pressure. So however you can assist in that process, I encourage you to do that. Whether it's talking to your lawmakers, whether it's writing letters to the editor, however you can assist that process, I think it's important to keep that moving forward. And why should you care, right? If you're not on Medicaid, why should you care? Well, again, as I covered, when they go to the hospital, they're driving up your costs. Whether they're driving up your taxes or whether they're driving up your premiums, they're driving up your costs. But also there's lots of reasons to care. So the federal government is picking up 100% of the cost of the Medicaid expansion in the first 3 years. And after that, it steps down to 90%. That's the most generous federal match there's ever been for a program like this. Probably ever will be. So for the state of Michigan, we're looking at saving over $1 billion the first decade, $1.3 billion the first decade. That's because the federal government, the Medicaid program, is going to be paying for services that we are currently paying for with state dollars. Right? So it's simple math. If somebody else is going to pay for something you're currently paying for, that's a savings to you. So we're looking at $1 billion in savings, even though it's going to step down eventually. It'll be a long time before there's any real cost to the state at all. It's all savings for the foreseeable future. And of course, we have the benefit of providing half a million people, roughly, health care coverage in our state. Okay, so this all sounds pretty good, but as the video indicated, somebody has to pay for this, right? Unless we want to put it on the kid's credit card and the grandkid's credit card, somebody has to pay for it. But that didn't happen. Congress paid for this when it passed the Affordable Care Act. So when you look on the left, that's a chart of various tax increases throughout history, and the red one is the Affordable Care Act. And you can see that although it is a tax increase, it's certainly not the largest tax increase. We've got President Bush, first Bush's tax increase of 1990 is larger, President Clinton's tax increase in 93 is larger, Ronald Reagan's tax increase in 1982 is larger. Of course, Dwight David Eisenhower's tax increases of 1950 and 1951 were the largest in American history. So it was a significant tax increase, certainly not the largest. And it pays for the Affordable Care Act. You can see the Congressional Budget Office has confirmed that the Affordable Care Act is paid for. It's not adding to the federal deficit. No one's children or grandchildren are paying for it. We are paying for it as we go. And repealing the Affordable Care Act would actually add $210 billion to the national deficit. And this is another way to look at this conversation, the deficit conversation. And this essentially just shows you what is driving the deficit in America right now. You can see the Affordable Care Act is not on it. It's not an option because it's not driving up the debt. What's driving up the debt are Bush-era tax cuts, wars in Iraq and Afghanistan, and the economic downturn. So it gives you a visual sense of what's happening in America. I think we lost our mind. Well, you can yell. Okay, so I'm almost done here.
1, 2.
Thank you, Brett. He has many talents. Okay, so we've covered the deficit issue, so let's just wrap it up with talking about who pays for it. So it's not a middle class tax increase. The video alluded to that. I think it understated that. The Affordable Care Act is essentially a tax increase on the wealthiest Americans to provide health insurance to low-income Americans and to make health care more affordable for middle-class Americans. Virtually every tax increase in the Affordable Care Act, the criteria is $200,000 in individual income and $250,000 for a married couple. Virtually any tax increase in the law, that's the criteria. We're always dealing with myths and rumors on the internet. For example, there was lots of talk about how there's a new tax on real estate transactions under the Affordable Care Act. That's actually true. There is a new tax if you sell your home under the Affordable Care Act, except you have to make $200,000 from an individual and $250,000 a couple, and plus you have to make $500,000 or more in profit on that transaction. So that's an example of these middle class tax increases. It is what it is. It's a tax increase on the rich to pay for covering low-income Americans. There are some other revenue streams. There's a fee on large employers, $2,000 fee on large employers who don't provide coverage for their employees. That's not a lot of money. It's about $10 billion in total that's going to generate. And also Medicare Advantage plans, the private Medicare Advantage plans are going to be reimbursed at a lower rate eventually. That didn't happen this year. It was supposed to, but eventually that's supposed to kick in. They're going to get reimbursed at a lower rate. So there's different funding mechanisms in place, but essentially it's a tax increase on the rich to provide coverage for low-income Americans and make health care for middle-class Americans more affordable. So that concludes my talk. I hope this was helpful in understanding the Affordable Care Act. If you need to speak to me, I'm happy to stay afterwards. Also, if you'd like to email me, my email is don@consumersforhealthcare.org. Consumersforhealthcare.org. Okay. So I think we're going to be transitioning to my colleague, Dizzy Warren. As I mentioned, one of the major challenges for us right now in Michigan is the fact that we're going to have 1 million citizens in just a few months, October 1, 1 million citizens that need assistance getting covered. Either they're going to be part of this hopeful Medicaid expansion population, or they're going to be eligible for tax credits to purchase private insurance. A lot of these folks are very difficult to reach. About a third of the citizens who are currently eligible for Medicaid don't sign up for Medicaid. Okay? A lot of reasons they don't sign up is they don't understand how, they need someone to assist them, there's nobody assisting them. So we're talking about expanding that population. There needs to be some support mechanism in place to help people get themselves enrolled, understand what their options are, and to help them. So under the Affordable Care Act, it calls for the creation of at least two navigator organizations in this state. Michigan Consumers for Healthcare is trying to create a consortium to deal with that. Jewish Family Services has agreed to be part of that consortium, and my colleague Dizzy Warren is going to be discussing some more detail. So with no further ado, are you all ready? All right, I'm going to pass this over to Dizzy.
Good afternoon or evening now. We've all been working around the clock, going around the state, doing presentations similar to this. So if I say good morning, it's because I probably didn't go to bed or something. So good evening.
Good evening.
Good evening. And I need to speak into the mic. First, I would like to thank our host, Representative Rudy Hobbs and Jewish Family Services, for sponsoring this event and giving us the opportunity to get some clarity about how is this going to impact us individually and in our families and as employees and employers. And so Don has given you a great overview, and the Kaiser Family Foundation video did a really good job of explaining this very complicated state that we're in today. And so what I'm going to talk about is to give you the third arm, you may say, of what this is all about. So in this Affordable Care Act world and getting the Affordable Care Act implemented in our state, there are a lot of different individuals, groups, organizations, and government that have a role in making sure that this happens. And for you as consumers, it's important that you understand the role that each of these entities will play. Because when it's your time, when October 1st come around, and you're looking for some health care insurance coverage, it is all of those players that you will more than likely come in contact with. So, Don already mentioned that we are a coalition of 200 plus community-based organizations. Several of them are in the room besides Jewish Family Services. We, in the past 2 years, have spent a great deal of time making sure people understand what the Affordable Care Act really is about. We have been fighting an uphill battle, trying to make sure that people understood or understand what the Affordable Care Act is, as opposed to what some folks wanted it to sound like Obamacare. Instead of calling it the Affordable Care Act, people call it Obamacare. And that was just another way of trying to create confusion. Those of us who really understand it says Obama cares. Okay? So, with that in mind, we've been spending a lot of time, as I mentioned, doing education, training of trainers. We create educational materials. We customize it based on different populations. Our organization has also offered groups and organizations and a few individuals what we call mini grants. These were opportunities for them to create a plan to talk to other people about the Affordable Care Act. We still have that program in operation for our members. We have done, and some of you guys might have seen it and might have even been in it, we did some programming with public service television with Detroit Public TV station, where we brought in people just like you to talk about health care, the lack thereof, and its impact on you. And we've also produced a number of other kind of large-scale formatted opportunities to have people talk, and that included symposiums, several conferences, a number of roundtable discussions we've held around the state. We do research, because there's a lot about this that we don't know, and in order to move to the next level, we need that information. So we've done a couple of research-based surveys, and then currently we are amping up our efforts to lead health equity-related initiatives throughout the state. Because even if everyone in this room is completely covered by with health care, there are still folks that will suffer adverse impact of health care from the healthcare field because of health equity-related issues. So we're starting to focus on that as well. These are some of our local, state, and national partners. We don't do this work alone. And I don't think you are going to get very far doing it alone either, or trying to do this alone. So these are some of our national partners. Include up at the very top, Enroll America. They are still a strong partner in our state. They've hired 9 individuals from our state to work in our state in neighborhoods. I believe Southfield is one of the communities that they will be working in. They'll be going door to door with people from those neighborhoods who have volunteered to identify residents who do not currently have health care covered. When October 1st comes around, they will share that information with groups and organizations like Jewish Family Services, who will be helping to get people enrolled. So Enroll America is one of our national partners. We have groups like Michigan Primary Care Association, who, for the most part, oversees all of the qualified health centers in our state, and so on and so on. You can see both small and large organizations. So what I'm going to talk about are those 3, I'm going to call them entities right now, but 3 entities that will impact your ability to get the health care coverage that you need at the price that you can afford. And that includes navigators, consumer assistance, and community-based organizations, and how you can interact with them. So, Don mentioned, and I think several of the other speakers mentioned, that we have a deadline, and it's coming up really, really fast. There's what's the period that's called open enrollment. And like at your job, where there's a certain period of time that you could get into a health plan or change it, same thing is going to happen in weeks, really, from today, beginning October 1st and ending March 31st of 2014. This is the 6-month period that if you are seeking health care insurance coverage, that's the 6-month period that you'll have a chance to do that, okay? And as was indicated in the Kaiser family video, if you don't, we don't think it's going to work out that well for you to try to get it afterwards until the next open enrollment period. Now, even though you'll start, you'll have the opportunity to start to enroll October 1st, the coverage won't start until the exchange is open. That marketplace that the Kaiser family video pointed to won't start until January 1st. So again, this is about open enrollment. So the current environment, what is that like? What are we in? What are we up against in order to get ourselves and our family members and our neighbors enrolled? In Michigan right now, you've heard a number of figures in different categories, but right now we have almost 1.2 million residents who are uninsured by any source, okay? And of that, around 1 million of those people are under the age of 65, otherwise they would be eligible for Medicare. So about 1 million of them, a little over 1 million, are less than 65 years old with an income less than 400% of poverty. These individuals, about 1 million, are most likely going to be eligible for tax credit or some sort of subsidized coverage in our state. Okay? Then we have about 69,000 plus children who are under the age of 19 in our state, and their family income is less than 200% of the federal poverty level. These 69,000 plus children are currently eligible for the current Medicaid program or CHIP program, but they too are uninsured right now. And then the bottom figure talks about that nearly 500,000 that Don mentioned earlier, the adults who are 18 to 64 years old, who have an income of less than 138% of poverty. These are the people that Medicaid expansion will cover. Without Medicaid expansion, I want to be clear, without Medicaid expansion, that 500,000 will have exactly what they have today, zero, no coverage. So it's in all of our best interest because it does impact us. It's nowhere else but in our wallet that everyone who has the opportunity and who is eligible get the health care coverage that they need. Now, these meetings that we're doing, we're calling them regional meetings because it's easier to do these kind of forums. We can't do them in every county, so we've grouped all 83 counties into 10 different regions. The region we're in now is number 9, second from the bottom, and this is based on 2010 census data. You'll see in Region 9, the population is around 2 million plus, and of that, you have 205,000, almost 206,000 residents in this region who do not have health care coverage. That's a huge number, almost 6,000 people. That represents about 16% of the population in this region, which is, if you remember the figure that Don talked about, the national average is around 15%. So in this region, the number of uninsured people is higher than the national average. And this is just a more visual demonstration of that. If you, again, look at the second line from the bottom, you'll see that it says 16.2%. And that goes back to the number of people who are uninsured in this region. We also have to, when we're thinking about health care coverage and helping our neighbors get the coverage they need, we have to also think in terms of things like race and ethnicity. And so, again, the second line from the bottom, you'll see that, and maybe it's not too clear because the blue is pretty deep, But you'll see that in this community, roughly 1.6 million residents are white. About 234,000 are African American. About 5,000 Native Americans. Almost 93,000 Asians. And then the next largest group would be those who have identified themselves as being more than one race, multi-race, and that's almost 39,000. The reason that's important is because of how they need, what they'll need to help get enrolled. And we'll talk a little bit about that. This is just the same figures, but based on percentages. This is also important for our region. Again, look at Region 9. You'll see that in Region 9, it has the second highest percentage of the population from that region who are 5 years and older, who speak a language other than English at home. That's going to be really important for this area in terms of knowing that, getting folks ready to get insured. So to take a look at this map, it's hard to really see it, but this area here, these counties right in there, that's Region 9. And in Region 9, look what you see at the very top. How many languages are spoken in Region 9? 51 or more languages are spoken in Region 9. So that's another figure that is super important for getting people enrolled October 1st. Okay? And that, frankly, since the number is so high, it's probably going to be a member of your family, a member of her family, and so forth and so on. These are people we know that's going to need that assistance. So, what is the goal of outreach, education, and enrollment? It's super simple. It is simply to provide assistance and help people choose the right health care options for themselves and their families. And you can do that in 3 ways. These are the 3 ways that when you go and look for health care coverage, these are the 3 ways that you will, that'll be open for you. The first one is Navigator. Second one is Certified Application Counselors. And the last is Outreach and Education. So what are Navigators? We talked about healthcare exchange. That's going to be that marketplace where insurers compete for your business. And then connected to exchanges is an entity called Navigators. Navigators are entities that help consumers electronically, meaning over the internet, or paper application, and I should have added or phone because there's going to be a call center also, but help consumers prepare electronic and paper applications to establish eligibility and enrolled in coverage through the marketplace, that healthcare exchange marketplace. A navigator can pretty much be anything. It could be a for-profit, a non-profit, it could be a business, it could be a chamber, it could be a union. It could be pretty much anything, okay, including licensed insurance agents and brokers. And again, their job is to help consumers complete the application and get insurance coverage. The federal government, through this law, the Affordable Care Act, states that there must be a minimum of 2 navigators in every state. Now, we are what is called a federally facilitated exchange state. What does that mean? That means that our state government gave up all rights to create an exchange for us, and so it fell to the responsibility of the federal government. So all of our interactions with getting health care coverage is going to come through a federally facilitated exchange state, meaning the federal government will install and operate our healthcare marketplace. So the role of a navigator then is, there are 6 things that a navigator does. Again, it could be an individual, or it could be a group or an organization, or so forth and so on, of almost any kind. And they have 6 things that they have to do by law. If you run into a place that advertises itself as a navigator, they must do these 6 things, and that is maintain expertise and in eligibility, enrollment, and program specifications, meaning they must know about the health plans that are available to you and be able to help you understand it. They have to provide information and services in a fair, accurate, and impartial manner, meaning they can't point you to one plan over another. Okay? They must also facilitate enrollment in qualified health plans. These are those plans that we talked about that's going to be available to you on the exchange, the silver, the gold, the platinum. They have to refer consumers who have any issues or complaints or questions regarding these plans, or about the coverage, or about their determination. They must be able to refer those consumers to the appropriate source, such as in our state licensing office, where they oversee the plans that are in the exchange. So that's the one responsibility our state will still have. They will still be monitoring the insurance products that are a part of the exchange. And so we might need to refer people. They also must provide that information, and this goes back to that ethnicity chart as well as the language one. But they must be able to provide that information in a culturally and linguistically appropriate manner. So you have 51 different languages in your community. You're going to really have to amp up in that area to be successful. And then, and that also includes they have to adhere to laws related to the American with Disabilities Act and things of that nature. So part of providing the assistance, so when you go and you need some of this, these are your rights, okay? So it must also provide this information in case where people might need things like interpretation or some kind of special equipment, maybe for hearing and that kind of thing. No one can be denied, okay? And the last thing is that all of this must be done by adhering to all of the privacy and security standards established by this law, okay? So those are the 6 things a navigator does. So when you go there, you'll know what is your right, in other words, to expect. This is law. Okay, so what are the requirements? Well, when you consider the population that we talked about, the number of uninsured, in most instances, these people have, quite a large number of these people would never have had insurance coverage. So they may be people who are living in your homeless shelter or some other kind of situation. Maybe they're people that are in other kind of, like, substance abuse kind of programs and so forth. So a number of these people would not have had insurance either ever or for a very long time because they lost their coverage through employers who may have left the area. And so you must be able to serve low-income, disadvantaged, and hard-to-reach populations. These are the people that's going to show up because other people are going to go online or get a paper application and do it themselves. They're not going to really need assistance. So the people that's going to need it, and again, these may be people you know, the navigators these are requirements for a navigator in order to be served, because remember I said no one can be turned away seeking help from a navigator. They have to, again, have people understand about the tax credits that's going to be, that they might be eligible for. They have to explain how the health insurance, the benefits, the cost sharing, and appeals processes work. They must be independent and trusted by the community to provide clear and correct information. That's going to be critically important to helping people understand what their options are so that they can make the best decision for themselves. And they also should provide this information, make sure that the information provided can be understood with those with limited English proficiency. Again, those 55+ languages that are spoken in this region. There are things that a navigator can't do or can't be. They cannot be a health insurance issuer, because how are you going to do that impartially? You can't be a subsidiary of a health insurance issuer. You can't be an association that includes members who lobby on behalf of the insurance industry. And they cannot receive any kind of consideration, directly or indirectly, from any health insurance issuer in connection with doing the work of a navigator. So in other words, protections against insurers from pointing you in their direction. So how are they funded? Because we are a federally facilitated exchange state, August 15th, we will hear an announcement of the 2 navigator minimum that will serve Michigan. The federal government is making an announcement August 15th, so we'll find out then who those navigators are. These are the sources that you will be able to go to, but until then, we don't know who they are. And as Don mentioned, Michigan Consumers for Healthcare, on behalf of our entire coalition, did apply to become a navigator to serve the residents of Michigan statewide. And some of our partners that are here have already been mentioned, like Jewish Family Services, just a picture of the region, the counties. We have set up a system so not only will you be able to go to that 1 navigator or that 2 navigators, but there's also will be some what we're calling regional lead navigators. Again, everybody's doing the same work, helping our residents get enrolled. And I'm going fast because I want to leave as much time as possible for your questions and answers. I'll skip that. Certified Application Counselor. This is the other group that you will get help from. These are folks who do exactly the same work as a navigator. The difference is they won't get paid. These are going to be volunteers for the most part in your community. And we expect there to be more certified application counselors than navigators. So, with that in mind, we want to open this up to your specific questions. And then I'd like to invite our colleague, Brett, up also because he's the treasure trove of information about individual opportunities. And we'll hand it over to Representative.
Thank you, Ms. Warren. Let's give a round of applause because we gave us quite a bit of information, and I know there are going to be a lot of questions. So I am going to, as one of my former mentors, Amy Levin, would say, I am going to do my best to imitate Phil Donahue. And I am going to go out into the audience, and I will give you the microphone. So I'm going to have the 3 of you guys kind of maybe come up here. Keisha, if you can bring a microphone up to the front that they can pass along. And then why don't we start taking some questions, because it is 7:30, and I kind of want to start wrapping up around 8 o'clock or so. So I see one question in the back, so I'm going to hustle to the back here. And Keisha, why don't you take that side? I'll take this side, you take that side. How about that? All right, now when I get a microphone, don't be afraid to give it back. You can't keep it too long.
I have a basic question. Do you see this impacting Medicaid? Or, I'm sorry, do you see this impacting Medicare, shifting people from Affordable Care Act to Medicare, or vice versa?
No, this is not going to have any impact at all on Medicare as far as shifting individuals off Medicare. Once you're eligible for Medicare, the expectation is you're going to get enrolled in Medicare.
Hi, I deal with dually enrolled clients with very high spend downs, and if they need their spend downs, they have no money left for the month to do anything.
Right.
Will the expansion get rid of his deductible?
Yeah. Brett Williams hasn't had a chance to introduce himself, so I'm going to let him answer.
Hi, yes. That's a great question. Currently, as you know, there's a lot of different qualifiers for that. when Medicaid expansion comes into effect in Michigan, it'll basically eliminate a lot of those qualifications to be based on income. So when you look at the range at up to 133% of FPL, currently for an individual it's going to be about $15,282, and actually goes to about $30,200 and change for a family of four. So we based solely on income.
So the law eliminates these categories. You don't have to be in a category anymore. You don't have to be in a group, as long as you meet the economic standard you're in.
Good evening. Actually, I have two questions. First, can either of you kind of expound upon the reason behind the delay in the small business to 2015? And the second question, how can you become an enrollment counselor?
I'll tackle the first one. The reality is the federal government was not planning on running all these healthcare exchanges. Well, one of the outcomes of all this obstructionism on various state legislature levels is the federal government is having to take on all these responsibilities it was not planning on taking on. Okay, so we are really down to crunch time. The federal government has to figure out what's important, what's not important, and what's really important is getting these exchanges up and running for individuals, uninsured individuals. That is job one. So because they have limited resources, remember Congress will not appropriate additional monies to hire additional staff to implement this, they had to make some tough decisions. So the tough decision was, let's postpone for 1 year the implementation of the large employer mandate. You said the small employer mandate. There is no mandate on small employers. As we covered, there's only a mandate on large employers for the full-time equivalent above 50%. So we're postponing that 1 year so we can concentrate on what's important, which is getting these exchanges up and running and allowing people who currently have no coverage access to individual coverage. And I'll let Dizzy tackle this second part.
Okay, to become a certified application counselor, right now, in fact, just happened in the last few days, the federal government has opened up an application process for social service groups and organizations who are interested in being what they call a marketplace educator, I believe, or something like that. But it's available online right now if you're a social service organization who want to help people and train people to become certified application counselors. That training then will be provided by the federal government, and that won't start until after August 15th. So if you want to see me later, I'll give you the direct link to that online application. And it's free too, by the way. All the training provided by the federal government is free. Okay.
I think you started answering some of my questions about having faith-based organizations such as my church participate as these volunteer counselors. We are located in the 48202 area in Detroit, which has a lot of population requiring, and I can see people coming asking for these services, and we need to be prepared to answer those. So how do we go about getting that preparation? Some churches will be operating as navigators, and that's an option, which means that church will have people who will take this free training provided by the federal government, and they can operate as a navigator. The other way is that church could apply to be one of these marketplace educators of certified application counselors as well. And again, I'll give you my card to give you direct link to more information about that.
We didn't get an opportunity to elaborate too much on what we are doing, but we mentioned that we have applied, Michigan Consumers for Healthcare has applied to be the nonprofit navigator. Dizzy mentioned that one of the minimum two navigators has to be a community-based, consumer-focused nonprofit. So we have applied on behalf of our coalition of over 200 organizations. So we are looking for local organizations that want to be part of that process. So please see Dizzy, who's spearheading that, afterward. The way that's going to work, assuming we're selected, that decision is made on the 15th, August 15th, is we will reimburse grassroots organizations who successfully assist people in getting enrolled. So if your local organization wants to get someone certified to be a navigator and you're assisting individuals under us as the umbrella navigator, we will reimburse you for every successful enrollment until the money runs out. So you'll definitely want to look at that option as well.
Hi, I have a question. If you, after a certain date, if you're not insured, what kind of fines and penalties?
Sure. The first year, there's a $95 assessment when you file your taxes. $95 for an adult, $47.50 for an individual child, or 1% of income, whichever is greater. And that slowly increases until 2016, where it goes to $695 for an adult, $347.50, I think it is, for per child, or up to 2.5% of your income, whichever is greater.
Do you want to explain the affordability waiver?
Oh, sure. The affordability waiver basically is you are not assessed any assessment if the product on the marketplace will exceed 9.5% of your household income. So hypothetically, if you don't qualify for Medicaid and you can't find a policy that is 9.5% of your family household income, then there will be no assessments at all.
I have a few questions here, but they're pretty short. You talked about that some services now would have no cost. Does that mean no deductible, or like for women's annual checkup?
Right. So what we're doing is we're trying to change the American healthcare model. So we're trying to go from a reactionary model where we're reacting to health conditions and health crises to a preventative model where we're training everyone to be preventative in their healthcare. The best way to do that is to make preventative services free. So we're doing away with deductibles and copays for a lot of preventative services. And as I indicated, women will have a free annual well-woman visit.
That's great. You also said that there would be a single form for small businesses. What about large businesses? Because I understand that was a complaint that large businesses had, that there was so much paperwork involved in this.
Large businesses are very distinctly different than small businesses. Small businesses, to file for a tax credit, would file Form 8941 through the IRS. Large businesses will not qualify for the tax credit by purchasing coverage through exchange, because it's actually mandated for employers of 50 full-time equivalents and larger. The tax credits are actually designed for the smaller businesses who do provide a level of benefits to their employees to help them cover the cost for that. There is some changes for large business as far as what tax forms are going to change. That I don't have yet. I do have a lot of updates on the Internal Revenue Service that come to me weekly. Some of those, not exaggerating, are over 300 pages long, so I read them as much as I possibly can. But I have not seen what changes on the forms for large businesses yet.
So if there are individuals here who run small businesses or you're members of the Chamber of Commerce, I just want to mention that Brett does a monthly webinar for businesses and the Affordable Care Act. It's free, and we also always post it on YouTube. So if you miss it, you can just go online and watch it. So we'd like to encourage everybody to sign up for that, or if you're a member of the Chamber, encourage your Chamber to take advantage of that.
You also said that premiums are down because of competition in the larger pool. Does this mean premiums for everybody, or just people who are going to the marketplace?
I was talking to the market, referring to the marketplace, the healthcare marketplace.
So generally, premiums would not be affected, just people going to the marketplace?
Well, I think premiums would be affected off the marketplace too because of competition, because anybody can go to the marketplace. If you could buy it cheaper on the marketplace, why wouldn't you? Even if you don't get tax credits, why wouldn't you? So the insurers know that. So the mere fact of the existence of the exchange is going to force all policies down, regardless whether they're sold on the exchange or not.
Yeah, because that's important, because if your employer is paying part of it, you're obviously not.
Right. And if you're in the market to buy insurance, please go to the healthcare exchange first, because that's the only place you get your tax credit. So if you're eligible for a tax credit, that's the only place where it gets applied. If you buy it outside the exchange, you pay 100% of the cost.
My very last one, I'm sorry, so many. You talked about Medicare prescriptions, that they would now be covered, but they always have been on a separate, additional policy. So these will now be covered under this act.
Closing the donut hole?
I'm talking about just prescriptions in general, because they were never part of Medicare unless you got additional insurance.
Well, yeah, that's actually addressed in the bill for the Senate right now. They're looking at a very progressive avenue to cover the prescription drug coverages and have almost an incentive for people to take a proactive approach in their health care but they're also looking for coverage of low-cost, multi-month prescription coverages and filling the prescriptions with a generic prescription if it's available. So they are being addressed.
There was something that came out just recently in Oakland County that they're giving some discounts for prescriptions. Is that any part of that act, or is this just something that we're doing here?
That could be part of the community health plan, or?
I don't know the context of the question, so I don't know.
Okay, thank you.
Did I overlook, I may have overlooked, but I didn't see adult vision and dental care on the list of services offered. I saw it for children, but I didn't see it for adults.
No, you didn't overlook it. It wasn't there. So the law does not require that adult vision and dental be covered as that base coverage. But that doesn't mean we can't do that. So Michigan can voluntarily make adult vision and adult dental part of that essential health benefit, that floor of coverage. The state went through a process, a very short process in our opinion, a very truncated process in developing that PHB, and essentially developed the cheapest, they adopted the cheapest model they could. But 2 years from now, we have to go through that process again. And that's a conversation that I think the public really has to have, whether we should expand that floor of benefits to include adult vision and dental, because that's our right as a state to do that. We can do that.
Okay, and another thing that I didn't understand, did you say that the governor refused to accept the funding from the federal funding that would expand Medicaid in Michigan? Did I understand you say that?
No, not the governor, the legislature.
Legislature.
Yes, so we had several opportunities to receive very significant grants from the federal government to implement health care reform. We had the opportunity to develop a state-based exchange. The examples I was showing you coming in from other states are state-based exchanges. So these are states that were first movers, they got ahead of the game, they cooperated with the law, they didn't resist the law. So what we're seeing is excellent results coming in from these states. We're not seeing results yet from the states that didn't cooperate. Michigan is one of those that didn't cooperate. We will not know our results until October 1st. October 1st, because it's a federally facilitated exchange, we're not going to know until October 1st. So we don't know if our rates are going up or down. But we do know in those states that did not resist, did not obstruct, rates are going down. So thankfully, we're going to have that to compare to next time and pressure policymakers to move forward next time in developing a proper state-based exchange. But I should point out that the state turned down, in total, over $110 million in no-match grants that the federal government wanted to give us to do this. Over $110 million, no match. We could just accept it.
I jump in just so I can make sure I can walk out the room still, right?
Yeah.
I would say that there was a very long debate about, how do we implement an exchange? Is this something that we can do here in the state of Michigan? But you have Democrats and Republicans, and I'm going to just be very blunt about it. Republicans saw this as a move to really expand government. They saw this as an initiative that grew government, and this is something that they were 100% against. And so I can't do that in a forum like this. Can't talk much politics, but I would say that there were 58 individuals that were against it in the House of Representatives, and then there was a caucus that I'm a part of that's 50. We were all for it. So how about I put it that way and try to be as politically correct as I possibly can in an event like this. But we had a lot of conversations about it, and it really put us at a disadvantage, as Don was saying, in terms of understanding what our plans will look like. There are other states who are able to get out there right now, compare plans. There are people that want to be competitive, they lower them. We're not getting ours to October 1st, and we won't have that opportunity because of some very right-wing approach to how we should run government, to be very honest with you. And I never do this, but I will say this: the governor was not part of that plan. Governor Snyder was very supportive of the exchange and was also very supportive of Medicaid expansion, which Don said should be done by the end of August.
Do you happen to know the Senate bill number for the Medicaid expansion?
Yeah, it's actually a House bill. It was introduced in the House, it passed the House 7631. It's House Bill 4714. It is substitute 3, draft 7.
You just need to know the bill number. 4714.
Okay, I'm famous for giving way too much information, sorry.
You know what, I think we only have one mic, so I'm trying to work both sides now.
My name is Ted. I have a great concern. I think it was touched on here as a political issue in Congress. It's my understanding there's been over 30 attempts to repeal what I call the Obama-Carey Act. If that ever gets passed, this is all smoke.
It would have to pass the House, pass the Senate, and the President would have to sign it into law. So it's not going to happen anytime soon. I'm sorry, sir?
Prohibition got appeal.
Right. Remember, Social Security has been around for decades, and there are lots of folks who would like to repeal Social Security. So we're never going to have 100% consensus about anything, any law, including laws that were as effective as Social Security was in raising seniors out of poverty. So we're always going to have individuals that oppose laws. But the reality is, as this law gets implemented, as people see all the good news and the changes in our society, it's just going to become more and more and more popular. So I just do not see it being a big deal.
Hi. Some employers may see this as an opportunity to retaliate against their employees because they have to provide insurance. So do you foresee the government placing limits on employee contributions to health care?
I'll let Brett go ahead and answer that.
Yeah, part of the law actually implements that. Large employers who provide level benefits to their employees, there's a maximum out of pocket for employees of 9.5% for the employee. The employer, it's actually against federal law to take a negative action to an employee because they want health care coverage. So I don't see that as a large hurdle that we're going to be facing in the future.
One of the earliest slides at the bottom showed the number of people who will not get health care even with this. I either missed the reason why or we didn't hear it.
I think you might be referring to it was something like 474,000. Yeah, that's the number of Michigan citizens who are currently uninsured, who have income of less than 138%, and where their only option for health insurance coverage right now is Medicaid, the expansion of Medicaid. So if we don't expand it, that's the number that will remain uninsured.
Ms. Warren, I just want to follow up on that. I believe that even in the video, it kind of ended with not everyone is going to have coverage under the Affordable Health Care Act. And I think that was more so the question, not necessarily the expansion of the Medicaid.
Right, and that's correct. So there are 10 categories where you do not have to purchase coverage or not mandated to purchase coverage. We talked about one of them, which is the affordability waiver, right? If you don't want to buy insurance and you can prove it's too expensive, you can receive an affordability waiver. Prisoners do not have to purchase coverage. Native Americans do not have to purchase coverage. So undocumented aliens are not eligible for coverage. So every undocumented alien in the state, they're not eligible. There's a myth or a claim that the Affordable Care Act provides coverage to undocumented aliens. It's not true. They're not eligible. So all those folks are still going to be out there. But I gave you the Massachusetts model, where even in Massachusetts, where this law is based, that it was the test vehicle for this law, even in Massachusetts, 1.9% are still uninsured. So they're still going to be uninsured in the state.
Right.
Good evening. I have a question that's going around my job. If the employer has to give you health insurance, if you work 40 hours a week, but you're not considered you're full-time, but you don't get the full-time benefits, will they have to cut you to part-time? That's what the issue is around my job. We're trying to understand if that's going to be true, that you will be cut from 40 hours to 28 hours a week.
That's a real tricky question, in all sincerity. How large of an employer do you work for?
Well, I work for the YMCA.
Okay. You know, I've heard that, and I can't really comment on that because that's kind of a business practice issue. I would like to have a sidebar with you. Maybe I can help you kind of look for things you'd like. But that's a kind of question we really can't directly answer because we don't have, what your practices would be in the YMCA.
Yeah, I would start by checking with your employer, making sure you have the 50 or more full-time equivalent, because we see lots of smaller employers making dumb decisions based on myths about the Affordable Care Act. So I would start there and make sure that would even apply to you to begin with, your employer to begin with. As we pointed out, employee coverage is going up, it's not going down. The vast majority of large employers, again, 98% of large employers above 200 employees already provide coverage to their employees. So it's that kind of squeaky wheel theory I was saying earlier, where the same small group of employers that don't provide coverage now don't want to provide coverage next year and are making a lot of noise about it, trying to figure out ways to avoid it. So I would begin there and even check with your employer, make sure your employer even understands that there is no mandate if they're under 50 full-time equivalent.
I just had two quick questions for Don. You mentioned that in order to pay for the Medicaid expansion, it necessitated an increase in the Medicare payroll tax of about 4% for individuals or families making over $250,000. Now, it's my understanding that that's not indexed for cost of living increases. So, ideally, if you're making like $150,000 now, then 7 years you would be considered wealthy because of cost of living increases. Is that true?
I've not heard that before. Have you heard that, Brett?
I have not.
You can check into it. It sounds like a myth, but I'm not sure.
Yeah, okay. I haven't heard that either.
Okay, and then my second question is, the first slide you had mentioned that the cost of health care for the U.S. was about $8,000 per individual, and it was substantially less for Norway and Canada and England and things of that nature. My thought would be that those countries have a single-payer option. So what would the reduction in health care costs per individuals be in the U.S., the individual mandates?
One caveat to that is I do not believe Japan has a single-payer system. Japan, if you think of rent control in New York, that's the Japanese model. So in Japan, they strictly restrict how much providers get reimbursed and how much they can charge. So that's not a single-payer model, and that's actually the most effective on the planet, I believe, in providing health care, and their health care is excellent. So there are other ways to do health care, but there's no question it would be cheaper to do Medicare for all. I agree with you, because obviously you're cutting out the middleman, you're cutting out the insurance companies. But again, that's a theoretical discussion, since the country was not interested in going that route politically. So our focus is on the law in front of us, not theoretically a single-payer system.
All right, so I'm looking at my clock. It is almost 8 o'clock now, and I want to be respectful of the credit union's time. They had us booked here from 6 to 8, so let me see the remaining hands. Let's see, 1, 2, 3, 4, 5, 6. And I'm calling it quits after that. All right, so I think I have the 6 in my hand, so I'll start here.
Hi, thanks for your time and information. This is a question about premium. I get it that if you're in the marketplace to buy a commercial insurance, your premiums over time, you have a good chance of that going down. How about those receiving Medicare? Do they have any opportunity to have their premiums positively impacted?
You're talking a Medicare Advantage plan, that sort of thing? Do you have a comment?
Yeah, actually Medicare is not affected by the Affordable Care Act as a secondary coverage or secondary policy. But working with ARP over the last 6, 8, 10 months, we have noticed that there has been different plans being offered that could save substantial money for the seniors. So it's kind of a wait and see what comes out. But yeah, we're looking that way that if you're going to try to gain, well, to give you an idea, in Michigan, the end of this year, there'll be more people over 50 than under 18. So they know that the competition to become greater, and I think they're going to step up to the plate and create that field of competition and try to get a better price for a lower price.
So we're clear, we're talking about Medicare Advantage plans, not Medicare. Medicare Advantage are private plans.
Absolutely.
You purchase these private plans as add-ons to regular Medicare.
Yes, Medicare is federal, Medicare Advantage, our Secretary of John said, is a private purchase plan.
Okay, so the Medicare, traditional Medicare, not Advantage, that your premiums aren't going to see any impact.
You mean positively or negatively? I cannot predict any positive or negative impact on Medicare Advantage, no.
Medicare Advantage, she keeps.
That's what I said, didn't I? Medicare Advantage.
Talking about Medicaid.
Oh, it doesn't impact Medicare.
Oh, no,
It doesn't impact Medicare.
I'm talking about Medicare.
Yeah.
Right.
Yeah, it doesn't impact.
Hi, when all of the healthcare reform was first starting to be, they had spoken about taxing people who have a Cadillac plan. Is that one of the things you said for over the 250,000, or is that going to be everyone? I heard it was like 2018 or something like that. How is that going to work, or is that still in the works?
Well, the Cadillac plans are actually a cost derivative plan. Because the plan costs over X amount of dollars and has a very, very wide level of coverage, and that can be taxed as a taxable income. The 2018 market that you're referring to is grandfathered plans. Now, what a grandfathered plan is any plan that's in effect from March 31st, 2010 can stay in effect, as a whole, unless dramatic changes have been made to the plan, to the copay, to the deductible, or to the coverage. Once that plan changes over a certain threshold, then it loses grandfather status and becomes a new plan. So there's actually two different parts of that question.
Well, will it be taxed, our
The
premiums?
well, again, there's the tax on premiums is another whole different portion to that. That's actually paid for by the insurance provider, not the individual. Now, the individual, there's a provision that could tax as an income if you're working on certain level plans, but that's, again, it's not technically the Cadillac plan. It's called proprietary planning, that if an employee has a richer level of benefits than somebody else, that can be taxable income to an employee. Long answer short, that's what that is.
That might be a sidebar question
to
ask right after.
Just a quick question. In regards to the penalty, for those individuals who qualify for Medicaid but choose not to accept it, will they be penalized as well?
Well, technically, they could be, but they would fall under that waiver. Yeah. But technically, if they're eligible for Medicaid, they should be signed up for Medicaid.
Come August 15th or soon after, when the Michigan Consumers for Healthcare, when and if you find out if you're chosen as the navigators, how will you inform the public? Will that be a thing?
You are here, the hoopla all over the state. No, actually, we have created we're part of, and that Navigator grant application is part of a 250-plus organization consortium. And so we'll do press releases, of course, the traditional thing. But also there's a whole bunch of marketing-related activities that will happen through the partnerships that are developed. And again, if there's any group or organization, whether you're a faith-based or community or other type of community-based organization, and you're interested in providing navigation services to your community, see me afterwards, because we're still looking for folks to become a part of that, especially from this area. Okay?
First, I'd like to thank you all for putting on such a good informational seminar.
Very, very good.
Thank you. And I'd like to ask, is there any limit to the number of insurance companies that will be represented on the marketplace? And secondly, are there going to be any kind of quality ratings or feedback mechanisms where consumers can express their satisfaction with services provided to help in the selection process? Rank order or whatever?
Well, why don't you tackle it first and then I'll...
Sure. Yes, currently there's 14 companies who have expressed interest in offering a product on the marketplace. The marketplaces absolutely will have the quality standards that they have to meet. There will be a complaint process. There will be an investigatory entity that if you have an issue, you can call them and get it reviewed. Part of the Patient Protection Affordable Care Act also mandates they have to be done in an expedient fashion. So they can't like lodge a complaint, they can put it on somebody's desk for a year.
Well, I'm thinking more like eBay, where you can judge the quality ranking of the provider,
Yeah.
they help in the selection process.
These are decisions that will be made by the exchange, and what we push very hard for a state-based exchange, but one of the things we push very hard for is that it be an exchange that was not unduly influenced by the insurance industry. Because there are decisions that exchanges can make that can help you as a consumer and help drive down costs. Okay, that would be a good example, right? They could provide some type of easy-to-access consumer feedback so consumers could look and see how these plans are delivering their services. Another way that the exchange on your behalf could save you money is they could force insurers to compete. So Brett said there's 14 insurance companies that want to compete here in Michigan for your money. The exchange can restrict the number that can sell on the exchange and say, we're not going to let all 14 of you sell your products here. You're going to have to lump in one another. We're going to let 8 of you sell your products. Or we're going to let 4 of you sell the bronze plans and 4 of you sell silver plans. That's called active purchase. And that's a very effective model, too. So that would be a possibility, too. So we want an exchange governing board, when we eventually develop our own state-based exchange, that can think about these things and can force insurance companies to compete against one another. That's not going to happen if the insurance companies control the governing board of the exchange. That's happening in some of these states. There was a push for that in Michigan. When we tried to do a law, there was an amendment to guarantee the insurance industry at least one seat on the exchange. Just a quick side story, when that happened in New Mexico, when they signed that same thing into law, a bill that said the insurance industry has to have at least one seat at the exchange governing board, the governor of that state interpreted that to mean at least one. And all of the members were representatives of the insurance industry. All 5 of his appointees were representatives of the insurance industry. So that's why we fight that so vigorously, because the governing board is not going to be able to make these decisions for you if it's controlled by the insurance industry. It's not in the industry's interest to be forced to compete. It's in our collective interest to force them to compete.
I would add that another way that you could make some judgment about the products that are offered has to do with the rate review that Don spoke about earlier. How much of the premium are they spending on your health care, and how much do they have to refund? So, and that'll be public information.
Ideally, you don't want a refund. Ideally, you want an insurance company that's putting all that money into your care.
Right.
If you're getting a big refund at the end of the year after year, that means an insurance company is charging you too much.
Hi, I just wanted to know, or to have clarity on, are you able to elect to go into the marketplace for your insurance versus accept the insurance that your employer may provide you, or are you mandated to take the employer plan? If they offer it.
If the employer offers you coverage?
Yeah, if they offer you coverage.
Go ahead. I saw you start to talk, so.
Well, no, this is my case.
Oh, okay.
Well, your employer is your first line. There is a provision that is being discussed right now by Health and Human Services and the Department of Labor that says, hypothetically, your employer offers you a line of coverage, you like it, it's well within the confines of what's required, but you decide that you want to go to the marketplace. What the law is looking at right now is that you are able to do that. Your employer would not be set to assessment because they've met the obligation to provide a level of coverage. However, the employer may, at his or her option, not provide a level of reimbursement for your health care. So say right now that they're paying, say $100 a month in your health care, if you go purchase it yourself, you may not receive that as a compensation benefit.
So a good employer would say, go ahead, go to the exchange, and we will reimburse you up to this rate.
Yep.
A bad employer is going to say, oh, gee, that's an excuse for me not to provide anything to you, and make you pick up 100% of the cost. So you would basically negotiate that with your employer. Either your union would, or you would negotiate that with your boss.
Okay, and the last question is, when would the premium start? Like, when would you have to pay them? If you enrolled in October, but the insurance doesn't start until January, when would you start paying your premium?
The premiums are due January 1st.
Okay.
Well, let's give Don, Dizzy, and Brett a round of applause. Well, we're going to bring it to an end here. I want to say thank you so very much for coming out to this conversation. we try to do our best in terms of really bringing in experts to really talk about very difficult issues, and I think we succeeded tonight. It was a great crowd, great questions, so I really appreciate it. We'll be in touch as, other forums come up, and we may have to do another one on healthcare, right? The conversation will not stop here, so we'll be doing more information. Just a couple housekeeping pieces. Jewish Family Services have a handout that talks a little bit about federal subsidies and premiums and can answer those questions for you. Our offices also, we have a handout, which I believe most of you have because the agenda is kind of tied to it, but it really talks about the benefit for seniors, the exchange, and also the benefits for young adults and children. And then we also have a frequently asked question sheet here also. And I also want to make sure that people have my telephone number. It is 855-REP-HOBBS. That's 855-REP-HOBBS, REPHOBBS. And then two more quick announcements. We have a small survey that I will ask everyone to fill out. If you fill it out here, you will not have to mail it in. So if you can fill it out and just leave it at the front table, it would be appreciated. And then I'll end with this, because I end every single form that I have, I love to share about something I'm very passionate about, and it's called constituent services. Most people, and people are going to get sick and tired of me saying this, but I'm going to have to drill this home because it's so important to me. Constituent services is something that my office provides every single resident in this district, regardless if you're a Democrat, if you're a Republican, if you vote, if you don't vote, it does not matter. When you need help, you start with my office. And this is why I give you my telephone number. You start with my office. I don't care if it has to do with your mortgage payment. If you can't make a mortgage payment, start with my office. Call me. If you can't pay a utility bill, start with my office. Call me. Because that is something that my staff, myself, we think this is the most important work that we do as your representative, is to make sure that you're able to stay in your house, keep your lights on, that you have food on the table, that you have heat or air conditioning, whatever. You can open up the window in the summertime, right? But in the wintertime, to make sure that you have heat. But, these are things and issues that we care a great deal about. We're very passionate. We do not drop the ball when it comes to taking care of the people of the 35th District. So, know that if you have a problem, you start with my office. If I can't help you, I promise you, I will find someone who can. Thank you for coming.